Welcome and thank you for joining our Men's Health webinar. I'm your host, Margaret. We'll start with a few housekeeping items and then I'll introduce tonight's speaker. First, your participation in tonight's webinar is completely anonymous to the other attendees. No one can see your face, your name, or hear you. If you wish to ask a question, please type it in the chat box at the lower part of your screen and we'll address these questions at the end of the presentation. Any comments or questions entered into the chat box can only be seen by myself and Dr. Granieri. Our presentation tonight will last for approximately 1 hour and will be presented by Dr. Michael Granieri. He completed his undergraduate and medical education at Northwestern University, graduating with distinction. He served his surgical internship and urology residency at Duke University. Dr. Granieri then completed a 1-year fellowship in male reproductive health and reconstructive surgery at New York University Langone Medical Center. During fellowship, Dr. Granieri received advanced training and certification in male infertility microsurgery at Cornell University Institute for Reproductive Medicine. Dr. Granieri has numerous publications and award-winning presentations to his credit. He remains a reviewer for several journals, including the Journal of Urology. Dr. Granieri is a member of the American Society of Reproductive Medicine, the Sexual Medicine Society of North America, and the American Urologic Association. Thank you for joining us tonight. I'll turn it over to you, Dr. Granieri, to get us started.
Yeah, thanks, Margaret. Well, I'm really excited to be here and just want to start off by saying this is my contact information at my office should you guys have any questions or would like to make an appointment to talk to me about anything from this presentation. So let's go ahead and just get started with our presentation. So the first topic we really want to talk about is erectile dysfunction. And the best way to start about this is to ask, well, what is erectile dysfunction? When somebody says, I have ED, what does that mean? Well, it's simply the inability to achieve or maintain an erection firm enough to have satisfactory sexual intercourse. And how common is it? It tends to be very common. So for men about 20 years or older, about 20% of them will experience erectile dysfunction in their lifetime. But as we get older, we see that it becomes much more prevalent. So after age 40, about more than half of men have some degree of erectile dysfunction. And this affects almost 40 million American men. So how does the erection process actually work? So with arousal, whether that's physical or visual, the nerves around the penis become activated or stimulated. And through the nerves, the muscles relax and we have an increase in blood flow to the penis. All this additional blood flow causes the penis to stiffen, and this erection compresses all the veins of the penis so blood can't leave the penis, essentially trapping it. And that's what enables the penis to remain erect. Okay, so why do people get erectile dysfunction? Well, there's 3 very common physical causes: vascular, diabetes, and medication. And for vascular, we're talking about things like risk factors being like hypertension, heart disease, even diabetes itself. And we also know that erectile dysfunction can also be a result of prostate cancer treatment and potentially a precursor to diabetes, heart disease, or valvular disease. Okay, so let's talk more about erectile dysfunction and diabetes. So we know that it can affect about 15.3 million men in the United States have diabetes. And we know that patients with diabetes are less responsive to oral treatments such as Viagra and Cialis. And we know that in men with diabetes, erectile dysfunction is more severe. And sometimes ED can be the presenting symptom of diabetes as well. So it's very much intertwined. And another very common physical condition that is intertwined with erectile dysfunction is heart disease. So symptoms of heart disease may develop within 2 to 3 years of erectile dysfunction. We know that erectile dysfunction is a risk factor for future heart-related events. And the severity of your erectile dysfunction is correlated with how severe your coronary artery disease is. And on average, erectile dysfunction precedes cardiovascular symptoms, heart attack, stroke, etc., in almost 70% of cases. And there's an old phrase or adage in urology that the penis is the window to the heart. And what this really says is that in men who start presenting with erectile dysfunction, it may give us a window to what their heart health looks like. And a lot of times we always recommend they get a cardiologist evaluation if they do present with erectile dysfunction as well. So why does this happen? Well, the arteries supplying the penis are much smaller than those to the heart. They're much more delicate and fragile. So any insult or blockage creates reduced blood flow. And smaller arteries typically are affected before heart disease symptoms. So you can look on this cartoon below. You'll see that the penile arteries are about 1 to 2 millimeters in diameter. And then the arteries supplying the heart, 3 to 4 millimeters, the carotids, 5 to 7 millimeters, and the femoral artery, about 6 to 8 millimeters. Another condition that's very much intertwined with erectile dysfunction is prostate cancer treatment. So we know that prostate cancer is very common, and erectile dysfunction is a very known common side effect of treatments for prostate cancer. And why is this? Well, the nerves and some of the blood vessels that supply blood to the penis for an erection, they lie very close to the prostate, and they may be injured during prostate cancer treatments. As you can see on this cartoon, there's cuts made to remove the prostate, and you can see the nerves that innervate for erections are pretty much hugging the prostate. And we know that prostate cancer treatments can affect a man's ability to have an erection on a temporary or permanent basis. Okay, so sexual dysfunction after prostate cancer treatment. It affects about 25 to 75% of men, so it's very common. And even with all the advances in prostate cancer surgery, such as the robotic surgery, erectile dysfunction may persist a year or more after surgery. And even after radiation, sexual dysfunction can occur up to about 50% of men. So it's very, very common after treatments for prostate cancer. Okay, so what are some of the treatment options for erectile dysfunction? Well, we do know there's oral medications like Viagra, Cialis, Levitra. There's penile injections, a vacuum erection device, urethral suppositories, and a penile implant. And we'll talk about each of these separately. So the first thing we'll talk about is oral medications, PDE5 inhibitors such as Viagra and Cialis. And how do they work? Well, in essence, they help increase blood flow to the penis. And they can be very effective. They're effective in approximately 60 to 80% of cases. Sometimes the efficacy can be affected by food. That's most common with Viagra. And they do have some side effects, most commonly headache, facial flushing, upset stomach. And I'll always counsel patients that if they're on, Flomax or taking nitrates for chest pain, that especially nitrates for chest pain, that we advise that they don't take those medications concurrently with nitrates for chest pain. So the next treatment option is intracavernosus injection therapy, or ICI, or penile injection therapy. How does it work? So we inject a medication directly into the penis, and typically an erection may develop within about 5 to 20 minutes. And what you're doing is you're taking concentrated medication and injecting it directly to the source. It can be very effective, but approximately 40% of men will discontinue therapy even after trying it, typically within 6 months. And there's a variety of reasons for this. Some of them are from the side effects of this, which include penile pain, prolonged erection, or priapism, which is just an erection that lasts longer than 4 hours. You can also have scar tissue or scarring of the erectile tissue from repeated injections. And sometimes you can have bruising or a hematoma, or blood collection under the injection at the skin site. And some of the more common reasons people will discontinue is that it doesn't work, or they don't get the erections that they want. They have some pain from this, or a lot of times patients just don't like doing injections. for a variety of reasons. They don't want to put a needle near their penis, or sometimes they don't feel it provides a lot of spontaneity. Patients don't want to have to go to their medicine cabinet or their fridge while they're in the process of wanting to make love, inject a medication in their penis, and then wait to see if it's going to work or not. Sometimes that can kill the mood, and that's a lot of times what patients will tell me. The next option is a vacuum erection device. And essentially what this is, it's a pump that creates a vacuum that essentially draws blood into the penis. And then there's a constriction device or an elastic tension ring that's placed at the base of the penis to help keep that blood there. And it can be very effective. There's patient satisfaction rates that are up to 80%, but there can be some side effects, including blocked ejaculation, bruising, discomfort, pain, or penile numbness. And some of the reasons people would say, it's not really for me, I'm going to stop using it, is that it doesn't give them the erections that they need. And sometimes they can have pain or discomfort, or they just find it a little too cumbersome to use. The next treatment option is a urethral suppository. So what this is it's essentially a pellet that you insert in your urethra after urination, and ideally an erection develops about 5 to 10 minutes later. Success rates are varied, about 40 to 66%. There are some side effects to this: genital pain or urethral pain, urethral bleeding, or blood in the urine. Sometimes you get low blood pressure and dizziness, and sometimes it can cause some scarring in the urethra as well. The reason people will try this but then say, it's not really for me, I'm going to stop using it, is because, one, maybe it doesn't give them the erections that they need. They can have some pain or burning. Sometimes they want to switch to another therapy, and sometimes they just get spontaneous erections again for a variety of reasons. The last option we'll talk about is the surgical option, which is the penile implants. And how does the penile implant work? Well, simply you're squeezing a pump in the scrotum, and what that's doing is moving fluid to create an erection. The cylinders that are in the penis fill with fluid, they get erect, stays that way, and then there's a pump, or there's a button on the pump that returns it to its flaccid state. It's very effective. I think that's one of the best features of this. About 98% of patients reported erections to be excellent or satisfactory after a penile implant. But there are some side effects or complications. You can have a postoperative discomfort or pain, infection, typically around 1 to 2% risk of infection, and rarely mechanical malfunction of the device. But we do know that on average, after about 7 years after it's implanted, about 94% of them are still fully working. So there's 3 types of penile implants. There's the most common one, which is the 3-piece inflatable penile prosthesis. And the 3 pieces are the cylinders that are in the penis, the pump that's in the scrotum, and that reservoir that's kind of right behind the pubic bone. And essentially, I call that the fuel tank that stores all the water. There's a 2-piece inflatable implant where essentially you just have the cylinders and the pump, and there's no fuel tank. And then you have a malleable implant, which are just 2 semi-flexible rods that get implanted, and there's no pump and there's no reservoir. So let's see how this works. Okay, here's an animation that's going to discuss or show us how this works. So with an inflatable penile prosthesis, this is a 3-piece, you're going to squeeze the pump in the scrotum. That's going to cause an erection to happen. So the cylinders are inflating with fluid. They get rigid. It stays up as hard as you want and as long as you want. And then when you're done, you press the button on the pump, and it takes that fluid from the cylinders and puts it back in the reservoir, and then you return to what we consider a flaccid state. So the process of getting a penile implant is such. Usually it's performed as an outpatient procedure under general anesthesia. That's personally how I do it, typically outpatient, general anesthesia. There's two approaches. You can have one where you have a small incision in the scrotum or one right above the pubic bone. And generally after a few days, you return to your regular routine of light activity. And typically you can start using this about 4 to 6 weeks after it's implanted. You'll be able to start, you learn how to use it and hopefully be able to resume having sexual intercourse. Okay, cost and coverage. So unfortunately, insurance coverage for erectile dysfunction treatment varies. All right. We know that incontinence treatment is commonly covered by insurance, but for erectile dysfunction, a lot of it just depends on the insurance company and also the specific plans within that. We do know that Medicare is very good about covering penile implants. I've never had a Medicare patient denied for a penile implant. But I think the key thing to remember here is don't let cost be a barrier or insurance-related issues. There are ways to kind of work around this, and I think it's important to talk to your urologist, and they can help work with your insurance company or manufacturer to figure out your benefits and even help to see if we can get the implant approved by your insurance company. Okay, so what are the main benefits of a penile implant? Well, we do know it's proven. There's about 97% patient satisfaction, 98% partner satisfaction with the 3-piece penile implant. So that's very, very, very high satisfaction rate. It's clinically proven to reduce the risk of infection. In general, it can be very affordable. It's typically covered by insurance and Medicare. It's very durable and long-lasting. So it's a permanent and concealed solution that can typically last, on average, about 15 to 20 years. We do know that about after 10 years, 89% are still in use. And the other thing, too, is it looks very natural. The whole process is much more natural. It's designed to maintain a natural-looking appearance in both the erect and the flaccid state. It typically does not interfere with your ability to ejaculate or orgasm. And in general, it's spontaneous. When you're in the mood, you can dictate, when you want an erection, how hard you want the erection for, and how long it's going to last. So, but as we do know, with any surgery, there are some risks. And there are risks involved with any surgery. Not every patient is a candidate for a penile implant, and it's always really important to discuss the risks and benefits of this procedure in detail with your doctor to figure out if it's the right procedure for you. Some risks of the penile implant include the following. So you're not going to get natural or spontaneous erections anymore. And any other treatment options that are not surgical, such as pills, injections, etc., those are going to be rendered ineffective. There can be a mechanical failure of the implant, which may require revision surgery. There is some pain associated with surgery, but that typically short-term, but sometimes you can have a little bit longer-term pain. And then we do know there's a risk of infection with this, typically about 1%, but some patients, such as those who are diabetic or have history of spinal cord injury or any open sores, they have an increased risk of infection. So just to summarize erectile dysfunction, we do know it's a common problem. It may be associated with other conditions, and very commonly it is diabetes, heart disease, and prostate cancer treatments. Fortunately, there's a variety of very good treatment options, and one of those options, a penile implant, could offer a long-lasting and satisfactory solution. If you want to learn more about this, you can always go to edcure.org. And here's some more information about edcure.org. Okay, so let's switch gears and let's talk about male stress urinary incontinence. So what is it? Well, typically it's male bladder leakage. And what that is it's when somebody's a male cannot stop the flow of urine when they're either coughing, sneezing, laughing, lifting, bending. Any valsalva maneuver typically can provoke a leakage. And it's very common worldwide. About 500,000 men will suffer from stress incontinence. All right, so it's important to understand the urinary process before we kind of talk more about stress incontinence. So the bladder, its job is to store urine and then expel it via the urethra. There's a sphincter muscle that surrounds the urethra. And that muscle, when it's contracted, keeps urine in the bladder. And then when the sphincter muscle relaxes, urine can freely exit the body. So there's some conditions that are associated with stress urinary incontinence. And one of them is prostate cancer surgery. And in my practice, I find that it's very, very, very highly correlated. Up to 50% of men report leakage immediately following surgery for prostate cancer. And about 9 to 16% of men will have incontinence 1 year after treatment. Now, it can also be a result of other less common conditions, such as neurologic disorders, any surgeries people have for BPH or enlarged prostate. Sometimes it can happen to people who've had radiation for pelvic cancers or for prostate cancer. And it can also be a result of pelvic trauma. Okay, so let's now focus more on male stress urinary incontinence and prostate cancer treatment. So approximately about 70,000 radical prostatectomies are performed each year. And about up to 15% of men will have persistent post-prostatectomy urinary incontinence 1 year after treatment. Now, there are some short-term options to see if this will recover. You can reduce fluid intake or take planned restroom breaks. But more commonly, pelvic floor physical therapy or Kegel exercises and biofeedback. And in addition, while that's going on, patients will typically use pads or diapers, catheters, and less likely penile clamps. But there are some long-term solutions for patients who suffer from what we consider permanent stress urinary incontinence that persists a year or so after their treatment for prostate cancer. One of them is a male sling. And the benefit of this is it's very undetectable. Nobody will know that you have it. It's very concealed. There's a high success rate achieved with patients with mild to moderate stress incontinence. So typically, that's about 3 pads or less a day. Most patients are fully continent immediately following the procedure, and it operates on its own to restore continence. So there's no pumps or buttons to push. And patients are very happy with it. About 92% would say, hey, yeah, I'd undergo this again, or I'd recommend it to a friend. So how does the male sling work? Well, essentially what it does, it's like a hammock or a support to reposition the urethra and restore bladder control. And as you see on the bottom, about 94% would recommend a sling procedure to a friend. The other option is an artificial urinary sphincter. Now, this is considered the gold standard treatment for male stress urinary incontinence. And it has a very significant impact on your quality of life. It provides proven, discrete bladder control. It's typically undetectable to others. It very closely mimics a healthy urinary sphincter. And most men with weakened sphincter muscle achieve continence. So how does this work? Well, there's 3 pieces. There's a cuff that goes around the urethra. It's almost like a belt that's around the urethra. And when it's inflated, it keeps the urethra closed. And there's a pump in your scrotum, and you squeeze this when you feel the urge to go to the bathroom. And then the cuff opens and then automatically reinflates from this pressure regulating balloon. So those are the 3 pieces to the artificial sphincter. And we'll just look at this video to give us a more detailed idea of exactly how this works. So when somebody feels the urge to go to the bathroom, they would just simply press this pump. It opens up the cuff, and then urine comes out, and then automatically refills on its own within typically about 2 minutes, and then that's it. So it's a simple pump when you want to go to the bathroom, and that's it. And because of its high efficacy and ease of use, there's a very high patient satisfaction rate. About 95% of patients are satisfied with the device. 90% would have the surgery again, and about 94% would recommend the device to a friend or a family member. Okay, cost and coverage. As we talked about before, the insurance coverage for erectile dysfunction varies, but with stress incontinence, we don't have that problem because it's typically covered by all insurances. If there's some situation where it's not covered, once again, talk to your specialist. They can work with you, your insurance company, to figure out how to get this approved, if it's possible. Okay, so let's just summarize the benefits of stress urinary incontinence products. They have the ability to achieve full continence, give you the ability to urinate when desired. A lot of times they're discreetly placed entirely inside the body and it's undetectable to others. And there's very high patient satisfaction rates. And I find that some of the happiest patients in my practice are the ones who've suffered from stress urinary incontinence and then who get either the sling or the sphincter and their continence is restored. And what this really does, it helps restore normalcy of the urination process and renew confidence. And there's a great quote on the bottom of the screen. It says, "Part of me was dead after cancer. Now, not having to worry, wear pads, and be able to be in them again, I have a new life. I am very happy." So, but as we know, there are some risks to any surgical procedure. Not every patient is a candidate for a male sling or a sphincter. And once again, you should always discuss with your doctor or urologist the risk benefits of each and figure out which one would be the best option for you, if any of them would be. For a male sling, there are some side effects that include, but not limited to, failure of the device, urinary retention, postoperative pain or discomfort, irritation at the wound site, and any foreign body exposure, okay? I.e. there's mesh in your body, but typically it's very well tolerated. With an artificial sphincter, there are possible side effects that include, but not limited to, device malfunction or failure, and that may require revision surgery, erosion of the urethra in the cuff area, urinary retention, infection, pain, and soreness. Okay, so let's just summarize stress urinary incontinence. We do know that unfortunately it's a known side effect of prostate cancer treatment, but fortunately there are a variety of very good treatment options. In the short term, the options can be effective, but they can be expensive and uncomfortable. And for the long term, a sling or an artificial sphincter could offer a fantastic solution. Should you desire to find any more information about this, you can always go to fixincontinence.com. And here's some more information on how to go to fixincontinence.com to get solutions for your male bladder leakage. Okay, so